Thank you, Natalie. I'm Panjan and a patient as well. I'm also the head of the Norwegian Hypopara patient organization. And I want to welcome you all to this first session with adaptation of hypopara treatment in everyday life. Let me mention, you said, Natalie, that you was not able to reach for Hypopara Sweden, and I know that they have closed down their organization. That's sad for the members, but they was not able to have an active organization any longer, so they have closed down. But now I want to introduce Simone Jentz. She's from Germany, and she is the patient expert in this first session. She is a board member of the patient organization Netzwerk Hypopara in Germany. And she will be the patient expert at this first session. And now I want you, Jens, to take the word to present the other speaker.
Thank you very much, Perianne, and good morning, everybody. It's very nice to be here and enjoying a session on hypoparathyroidism, the clinical aspects. It's really important, a really important topic. The society, the European Society of Endocrinology, has, as said by previous speakers, been very engaged in the area for at least 10 years. Hypopara somehow came up around 2013 when the society decided to develop the first clinical guideline on management of this important, however rare disease. And here we are, as said, 10 years later with much more knowledge and also perspectives for the future. Today's program, I'm very pleased to introduce the first speaker, which will give the talk on adaptation of hypopara treatment in everyday life, the clinical perspective, by Professor Heide Siegelkalb. Heide is the head of the working group of molecular endocrinology and osteology at the University of Göttingen in Germany. She works in an outpatient clinic for endocrine and metabolic diseases, including bone diseases and osteoporosis, hypopara, and orphan bone diseases. From the society's perspective, she has been very active in interacting with our society and since 20 been a member of our education committee. Her clinical research is now focused on secondary forms of osteoporosis and on parathyroid disorders. And especially, she is a super expert in quality of life. Heide, please go on.
Thank you very much, Jens. Thank you all. Good morning, everybody. I start my presentation. So my task today is to talk about the clinical perspective of adaptation of treatment. So these are my disclosures. And I would like to start with a poll. So I tell you before the questions, before we start the poll. So, adaptation of treatment. A, no, I did not adapt treatment. Did you already adapt treatment? No, I did not adapt treatment. B, yes, but without telling my doctor. And C, yes, in cooperation with my doctor. Please do the poll now.
Sorry, Heidi, we're just having a technical problem with the poll. Give me 2 seconds.
Okay. So shall we do it later?
Yeah, if you want to carry on just for a second, thank you. I'll let you know.
Okay, thank you. So what sort of treatment do we have right now? We have a treatment, conventional treatment with vitamin D analogs. In addition, we have calcium supplements in divided doses. We supplement with vitamin D, 400 to 800 international units, and magnesium if needed. We also have hormone therapy with or without activated vitamin D analogs. you can use recombinant PTH 1 to 84 in countries where it's not available, teriparatide, and in the future, according to the European Medicine Association, Palopec teriparatide, which will be probably available in the next year. So when do we use hormone treatment? When conventional therapies, so from the guidelines or from the, when it's told, when conventional therapy is deemed unsatisfactory, the panel considers the use of parathyroid hormone. So where should the values be? Calcium should be according to target range, lower half or normal or just below. Magnesium in the normal range. So hypercalciuria should be avoided. Hypophosphatemia should be avoided, and then you can take calcium supplement with meals. Vitamin D should be in the reference range. And if you have to adapt, a low phosphate diet can be used, a low sodium diet to reduce hypercalciuria, or also use the use of thiazide diuretics is possible. So, what about the normal levels of calcium in the blood? And to find this out, I looked at the literature and I find a publication from Lars Reinmark, and what they did, they investigated for 3 different diuretics compared to a placebo. And we just look at the placebo because this is what we are interested in. So what about calcium during 24 hours? And what you can see is that calcium levels during the day is not stable, but is fluctuating. Also, when you look at phosphate is also fluctuating. It was higher during the night and goes down in the morning. What is about active vitamin D levels? Also, active vitamin D levels fluctuate during the day. And if you look at PTH, you can see that PTH also is not stable during the day. So when we look at how big the variation is, we have 2 to 3% of calcium, 10% of phosphate, and 20%, around 20% in 125 vitamin D and in PTH. So what we know more about PTH is that there's a pulsatile fashion of secretion, so that it's not stable even in the short term. This is what we saw already, what is during the day. But what we know also, but just from really few data, is that if you are doing sports, PTH increases by 70%, and serum calcium increases by 5%. Therefore, on effort, more is needed. So what is the difference of hormone treatment and 125 vitamin D? So just to remind us, and I know there were some questions already, so just to remind you that if calcium goes down, PTH increases, and calcium is there, it comes from the bone, it will be resorbed in the kidney, and 125 will be activated in the kidney. And only 125 vitamin D is possible to increase calcium resorption from the gut. And if it's in the blood, it can't go out by the gut, it only can go out by the kidney. And what is the difference between both? What is the most important in this case is that phosphate with PTH is that excretion is increased, so phosphate in the blood goes down, and 125 increases phosphate resorption. So phosphate is higher in 125 treatment. So what about adaptation of treatment? So if you want to adapt treatment, we have to know that calcium resorption is dependent on how much the intake, the less we take, it's more is resorbed, it's better with meals. And we know that when we age, then resorption is decreased. What is very good is that we know that calcium is available from different sources. You can use mineral waters in comparison to milk and supplement. And when you look that there's an effect on PTH, you can also see that if they're in healthy people, you take it in, there's also an effect on PTH. And when we compare the difference, I don't think there is in the short term a really huge difference between mineral water, and there seems to be a little bit longer duration if you take milk, but otherwise in the short term, the increase is pretty good in all the with all the different sources. So what about the time until calcium increases if we take calcium? So here different availability of different calcium salts, and if you look, this is like 60 to 90 minutes. It is needed so that calcium is resorbed and calcium increases. So when calcium is taken, and we can increase this by 0.1 from 60 to 90 minutes, and the best one are calcium salts available like a powder, a soluble powder, or calcium citrate is the highest, but also the others increase calcium. So this is the ones who are the best available. So is there a difference between citrate and calcium carbonate? There is a study in hypopara patients to know that so serum calcium phosphate concentration in serum was not different. There were no difference in quality of life. There was no difference in calcium oxalate index in blood, what they investigated. There was a little bit difference on oxalate in the urine, which was better with citrate, and there seems to be a little bit less constipation with citrate. So I think this is assuring that also calcium, the different calcium salts are not too different. So can we also adapt with active vitamin D? And just to show you that in 6 hours, active calcitriol goes high very fast. Alpha calcitriol is lower and needs longer to be active. But if we look at the calcium values, you can see that it takes until the increase in calcium values, it needs like more hours, 12 to 18 hours, if it really increases. So for the short-term adaptation, this seems not to be useful. So is there a difference between alpha calcitriol and calcitriol in the treatment? So there is also a study, like a crossover study, and what they conclude is that both lead to comparable but high serum phosphate, hypercalciuria, and physiological circulating active vitamin D levels. So, so no real huge difference at the end. So what about calcium levels with hormone treatment? Can this be an adaptation method? And there we have again data from Lars Reinmark group, and they investigated PTH 1 to 84 and how this works in the short term on the calcium levels. And there you can see that in 2 to 4 hours, there is a calcium increase while using PTH 1 to 84. And these are data on PTH 1 to 34. And you can also see that it takes like 4 hours that there's an increase in calcium in the short term. The other one is the pump. So what about the new Parlopec teriparatide? This has a half-life of 60 hours. So here are shown days of adaptation of calcium levels. So this is due to the long half-life, probably not useful for adaptation of treatment. So in summary, and some personal comments. So in healthy persons, PTH we know increases during the night and increases during physical exercise, and possible in other situations in daily life, emotional situations, stress. Perhaps it's a little bit like in endocrine diseases, also cortisol, which also increases during different stress situations. We don't know this exactly. So in hypoparathyroidism, this does not work anymore, so it's out of order. So there might be situations in daily life which might profit from adaptation of treatment. So, and what I know from a patient who runs marathon, that the adaptation of treatment makes this kind of sports at all possible. So metabolism of the different vitamin D forms seems not to be helpful due to the later effect. So calcium salts taken by mouth increase the calcium levels by 0.1 in less than 1 hour. So this seems to be helpful. In some patients, calcium taken before exercise and the next day is helpful for stable calcium levels. And this is the method some of my patients use in additional magnesium just to decrease the calcium load. Actually, to my knowledge, there are no studies on treatment adaptation at this time point. So what I think is important, every patient with hypoparathyroidism is different. What might be good in some can be bad in others. So please do not adapt treatment without prior discussion with your doctor. Thank you very much for listening. Here we have the poll. Did you already adapt treatment in different situations? No, I did not adapt treatment. B, yes, but without telling my doctor. Yes, in cooperation with my doctor. So please do the poll now. Okay, so this is great. So I see that more than 50% already adapted treatment together with their physician. But there's also some who already have their own experience and had their all experience, and that just 10% or 12 did not adapt treatment. So we know that this is already used nearly every day. Thank you very much for doing the poll.
Simone, then the word is yours.
Thank you very much, Pernian. I'm going to share the screen now. Okay, so first I'm going to talk a little bit about me. I had a complete thyroidectomy in April 2018 and have had hypopara ever since. There are only two things I do well in life, psychology and real estate. I'm a fully licensed psychotherapist in Germany and also an ISO licensed real estate valuer. I'm, as Pernian already mentioned, a board member of the German Hypopara network, and hopefully in December or January, my self-help book comes out, the Little Hypopara book, both in German and English. Before we start, I would like to give a little disclaimer. Please do not change your medication or introduce any additions into your daily regime without consulting with your doctor or therapist first. Also, I'm talking about my personal experiences and what works for me. So please view them as suggestions rather than guidelines. And please also recognize the limitations of self-healing. If in doubt, seek professional help sooner rather than later. I know sometimes it's a bit difficult to find a good supporting healthcare, but please don't stop trying. Next, what I'm in the light of what I just said is I want to give you insight into how I think and the mechanisms, how I adapt treatment, rather than giving you a recipe like I do this, I do that. Because what I want you to do is to find your own way, because you need to find your own best treatment, and it's different for everyone. The insights I had when I was diagnosed with hypopara is it's incredibly difficult to get a grip on the disease, and it needs to be actively managed. This is something that was totally new for me. Normally you go to your doctor tells you what you have. He prescribes, for example, some pills or physiotherapy. You do that and the disease is gone. And it's so different with hypopara. Also, there is, at some point, you feel the need to adapt the treatment, especially if you do not have a uniform lifestyle. My job requires me to travel a lot, and so that was really difficult. Another thing that really struck me was there is no psychological concept and zero psychological support. I will elaborate later on these points. And when I had this, I was, just to get a grip on the disease, I would formulate objectives for myself. Firstly, in the mind, to understand the disease, because there is not much information, there wasn't much information available. Then regarding the body, which is medication calcium, which is also, I'm not going to elaborate this today, it's kidney health and nutrition. And also on the spiritual side, like a psychological adjustment. And I'm also not going to elaborate on, is stress management. As Heide said, cortisol is also an important factor, and it's the stress hormone, to put it very easily. The tools I used were research, observation, introspection, connecting with other hypopara patients, and challenging myself. Challenging myself is an important point, because what I sometimes meet also in other people is, suicide for fear of death. And as much as this, as hypopara is really can impair your day-to-day life, you shouldn't shut yourself away. There are still things you can try, and you can, if you are careful, and if you then get to a point where you can really manage your disease well, you can reach a very high quality of life. When I talk about adaptation of treatment, I will talk about calcium, because as Heide already said, it is, you do not see the effect when you adjust vitamin D. Also, vitamin D is a hormone, and this is something that should be done definitely by your doctor. So I'm talking, it's short term when you feel, okay, you have, there's a bit of lack of calcium. So this is what you do. There are several challenges. There is no way to determine the calcium level during the day. And calcium levels in the body can change very quickly, because your body lost the ability to provide the right amount of calcium. It's a bit like a car without a fuel pump. A fuel pump in a car makes sure that whatever speed you are going at, there is the right amount of petrol going into the cylinders. And this is, actually, we are like a car without a fuel pump. So sometimes it seems like mission impossible, but you have to adapt. What you can do is you check with yourself during the day. When you do that regularly, it only takes a few seconds just to look at yourself and say, okay, do I feel a tingling anywhere, or do I feel a bit foggy in my brain? Also, this is important. You have to learn your individual symptoms of hypo and hypercalcemia. Is also to prepare and explore and learn what to do when, and I'm going to elaborate on that later. As Heide already mentioned, calcium should be taken in several doses over the day. This has also the advantage that, for example, if you have a slower day and you feel you don't have to take that much calcium, you can easily adapt. The difficult thing is, however, you have to keep track on how much calcium you are taking. You can also set an alarm as for drinking, and you can try alternative forms of intake when you're traveling or during work. What you can also try is food and supplements can interact with levothyroxine. If you are taking thyroid medication, you do not have to take it in the morning. I find it easier to take it before bed, because in the morning I often forgot to take it. Also, L-thyroxine can interact with calcium, and so I find it easier. However, there are studies showing that bioavailability of levothyroxine is higher when taken before bed. So this is something you absolutely have to do with your doctor. Prepare and explore different situations. As I said, you have to observe yourself, and it gets easier. For example, if you do a lot of exercise, you might need to need more calcium. When you're going on a shopping spree, traveling might be less or more, depending on, if you spend a day on a plane, it might be less. If you are sightseeing, it might be more. Concerts, festival, and I do not read them all aloud. You can see for yourself. These are situations, and if you make a mental note while you are in these situations, how you feel. If you feel you have to adapt your calcium level, you can prepare in the future. Also, you should learn what to do when. If, for example, your calcium level is too low, you can take supplements, or you can eat or drink calcium-rich foods. If your calcium level is too high, you can exercise. What works well with me, although again, check with your doctor, is soft drinks, because they contain so much phosphate. Or you can drink coffee. This is a possibility as well. I talk about psychological adjustment. Very often, when we talk about psychology in hypopara, we talk about depression and anxiety disorder. Actually, no one talks about loss or grief. And I think that's a mistake. It first occurred to me during the financial crisis in 2008, 2009, when many people lost huge amounts of money, sometimes their entire fortune. And they were absolutely not equipped to deal with this loss. And society in general doesn't equip us well to deal with loss. It's, first of all, loss is almost exclusively linked with the loss of a loved one. Most of the time we receive an intellectual answer to an emotional problem. Sometimes we say, yes, it's very hard to deal with hypopara, and people say, oh yeah, there are people having it worse. Well, that might be, but that's an intellectual answer. And often we are left alone when we would really need support or company. Sometimes people say, oh yeah, this person needs to be a bit on their own, but I think it's counterproductive. How do you deal with loss? What loss actually means is that your eternal GPS doesn't work anymore like it used to be. You have to adopt your lifestyle. As Natalie said, some people have to give up work. They can't travel anymore, and they experience a real, decrease in the quality of life. So this is your internal map doesn't match your internal map before having hypopara. So this it's a kind of adjustment. So what you can do is you can observe, name, and feel your feelings. You can ask yourself the right questions, and again, challenge yourself, and never forget that you are the master of your fate. I'm sorry, this is very short, but it's the best I can do in this time. What's really important is seek professional help rather sooner than later. Because no one with a broken leg would just spend some time in solitude or wait for time the great healer to take effect. That would be absolutely ludicrous. And in this day and age, it is not a stigma anymore if you seek the help of a psychiatrist or psychotherapist. The summary. To get a grip on the disease, it needs to be actively managed. For some parts, there is a need to adapt the treatment in cooperation with your doctor or therapist. And if you want to find out how to adapt the treatment, in which situations you have to observe and actually immerse yourself into as many different settings as possible, again, with caution. And if we look at the psychological side, it might be better to work with the concept of loss than working with other concepts. And again, get support sooner rather than later in anything you do. And that was it. Thank you very much for listening. And I would love to have a poll right now as well. Please, Claire. Knowing what you know now, would you adapt your treatment in different situations? And you can read the answers yourself and then click on the answers. Okay. So that's great. I think we have an increase of people
Yes.
who would like to adapt their treatment. And it's good to see that most of us would like to do so in cooperation with their doctor. That's cool.
Jens, then I should ask the questions that we have got in. We have got a lot of questions.
Yes, maybe we should just start with whether Simone and Heidi would like to have an interactive discussion, if you have something to add.
Yes, I would like to ask Simone a few questions. Simone, thank you very much for really great, to hear about your experiences. I think it's it's a really valuable feelings that we hear. So what was your way to accept the diagnosis? What do you think, how did you do this?
I think the diagnosis itself, yes, you get the diagnosis and there is not even an entry point for a discussion. What I find super difficult is that the medical care is so incomplete. It's so extremely difficult to get an appointment with an endocrinologist to start with. Then it was very difficult to adapt to the fact that it doesn't get away. It doesn't go away, it stays. And most importantly, it's ever changing. And I do not know that I know people with chronic diseases. That was really, they get their medication at some point and then they adjust maybe every year or every other year. And with hypopara, there is so much, in adaptation to be done. The way I did it was actually educate myself about the disease. So I'm not alone. And what's very important is to exchange the exchange with other patients, and also forums like this, where you can get new ideas and you feel on top of things. That's important.
And do you have like a special scheme just to help perhaps the other patients? So how do you adapt treatment? Do you have like, I mean, we learned that's different, or we know it's different for everybody, but how do you do it, right? Like in physical or emotional stress, physical activity or emotional stress?
Actually, I really, I'm a big fan of checking in with myself. I'm what you call neurodiverse, and the great gift neurodiverse people have, they can spend a lot of time on the meta plane while appearing totally normal to everyone else. So it's not, it's something I regularly do, just checking in and say, okay, do I feel any symptoms? Do I have the need to adapt? I don't have a scheme because my life is so, I don't have a constant life. There is so much change during one day is different from the next. So I just go with my feelings, so to speak.
Punian, do you want to comment on this from your perspective?
Yes, from my perspective, I also will say that there's not one day that is the same. So, and I understand that many of our members have the same feeling that Simone tells about. Some of our members ask, what about the pain? And are there a standard treatment for the pain? Maybe Heidi could say something about how to experience that challenge and how to live with it.
When I said what we know, we investigated pain in our patients with hypoparathyroidism, and it seems to be that it's a kind of pain like fibromyalgia pain. So it's a lot of muscular pain, but it's also it seems not to be really dependent on calcium levels. So there is right now we have no explanation for it, but to my knowledge, they are PTH receptors in the muscles. So I guess it's not all patients have this problem. It's a number of, probably different reasons for it. But actually from my side of view, it might be an indication for hormone treatment. So this is a possible solution and it seems to be better with hormone treatment, to my solution. But it's not really explained by now, but our explanation is that PTH receptor in the muscle are probably a reason for those. There must be differences between patients concerning
So
this.
in general term, what you are saying, Heidi, is that point one, this is complicated because it's not just a question about having a steady state of calcium levels throughout, but it is also that hypoparathyroidism is a disorder where you are lacking not just one hormone, but actually two hormones. You are lacking PTH, which have widespread effects throughout the bodies, including the muscles, the bones, the kidneys, the heart, the brain, and everywhere. And then also we have the lack of active vitamin D, because it's PTH that's activating vitamin D. So it's a two-hormone disorder. And what's the future? How can we improve this in the future perspective? What are your expectations, Simone, to future management?
Well, what I would like to get more information, because as Heide said, there are no studies on how treatment is adapted, and I would really, like to know more about how other patients do it. What's the way to go? That would be my expectation.
And that's where our patient groups comes in, at the European and at the global level, that we can gain information from that. Pernille.
Yes. I will say that I will ask a question from one of our that has been sent in because something they wonder about is the role of vitamin D. And what is vitamin D including the treatment while it less advanced in the kidneys by the lack of parathormone? Because we know now that there is NATPAR is going out, so many of the members are asking what will happen when we no longer have NATPAR, and how will the treatment be?
So I think these are two different questions, and Jens can also comment on this. But it's like, I mean, it's like active. We give the medication with active vitamin D because the general vitamin D, 25 vitamin D, what we take with the nutrition or by the sun, is not activated in the kidney because PTH is missing. So there is no active or just very low active vitamin D general then in the body. And because active vitamin D is responsible for the absorption of calcium from the gut, we need active vitamin D for treatment if we don't have PTH. Okay, so this is the first question. And the second question is that the European Medicine Association already has approved pyrrolobacteriparatide for treatment in Europe. So it will be available, I don't know in which countries, but it will be available next year. And because we have 1 to 84 available till the end of next year, there will be a possibility to change. So this is very important for all those who have already hormone treatment, that there will be a substitution, at least in Europe at that time. So Jens, but please also comment on the questions if you have something to add.
Yes, I think actually that we should try to continue with some of the questions and just leave it here. And thank you so much for that. And Pernille, could you start out with some of the questions we have received?
Yes.
And then we'll ask the panel here.
Yes. We have got questions from Lucy in France. She is asking about the diet and calcium levels. It seems that the calcium carbonate is alkaline with a pH of 11.5, and she thinks that the metabolism ensure that the maintain of blood pH around 740. Does the pH of the foods we consume have an influence in our blood calcium? And if so, what food should we prefer? Which should we avoid? Simone, do you have an experience on what you feel that will help you and what is not?
Well, actually, as I'm very aware of the fact that hypopara can affect the kidneys, I usually cook fresh and drink a lot. So yes, actually, when we eat a lot of plants, you do not have to take care so much you do not have to care about so much about the acidity of your food, because it's almost it's alkaline for a very large part. And I feel that if I eat a balanced diet, it helps me a lot. You know, no processed food, no sugar, no alcohol. That's for me the way to go, because these are the biggest culprits.
Heidi, what would you?
Yeah, I showed you the data. That's the reason I showed you the data. So I think it's the most important thing is what if you take calcium, the variation is not very big. So the most important thing is that you can live your own on your own, like you want to live, like you want to eat and you want to eat the food, and then try to find out what is the best way for you yourself. But if you think all the time, I have to eat this, or I have to eat this, or should I take this calcium? I think the best way is to try to use the food you're going to use and try to adapt with this food what you like to eat. So not possible to think all day long about the disease. This is the problem. So that's the best way to. I think if you look at all the different calcium provided mineral water, milk has had a lot of phosphate, so this is not the best way to use the calcium. But if you have mineral water or calcium supplements, they will all work.
Jens, do you have a question for them?
Yes, we have received several questions in relation to pregnancy. The population of patients with chronic hypoparathyroidism is relatively young. I think in the bigger studies, the mean age is below 50 years, and thereby we will have a lot of women being in fertile life. How can we adapt management during planning, going through pregnancy, and after? Do you want to comment on that? We have, as said, received several questions in relation to this topic. Heidi?
Yeah, so I'm not a specialist in pregnancy and hypoparathyroidism. I have some patients who were pregnant and did it. I know there is now a publication on pregnancy and hypoparathyroidism, and this has to be really discussed individual in each situation, because it's very different how much you need during that time. You have to adapt 125, because 125 increases during pregnancy from but also the increase in calcium is lost in the urine during pregnancy. So this is really has to be individually planned, but it's possible, and the risk of is a little bit higher for pregnancy. That's in any case, but it's possible, and it has to be really good planned. But Jens, please comment on this. It's a difficult.
Again, from our perspective, being the doctors, the pregnancy is really a situation where you have to adapt the treatment of your calcium disorder, of your hypoparathyroidism. And the reason for that is that you do get activation of an old PTH in relation to evolution, an old PTH-related peptide that helps or go in and interfere with calcium metabolism. What I'm saying is that when you are planning a pregnancy, you should do that in coordination with your physician, your endocrinologist. And during pregnancy, it's very important to have a very close follow-up, because this PTH-related peptide, the PTH-like hormone produced by the placenta, will increase, especially during the later part of the pregnancy. Thereby, you have to adapt your medication. And going from pregnancy through delivery to the postpartum period, again makes it a little bit complicated, because the PTHRP is not only this evolutionary old hormone, is not only produced in the placenta, but also in the mammary gland. Thereby, you will have, again, after delivery, to adapt and be closely followed up and adapt your treatment. Several patients can go totally out of medication in the later part of the pregnancy, and then have to start up later on after delivery when weaning. So it is complicated, and it is a situation where you have to be in close contact with your doctor, your endocrinologist, and you have to be followed at least I would say around 4 weekly basis throughout pregnancy and the earlier phase of the postpartum period. Do you want to comment on this, Simone, Pernian, Heide?
Perfect.
No, perfect.
Pernian, further questions from the board?
Yes, we have one from Natalie. He was asking, what options do we have at hand to adapt the treatment according to our different activities? Is taking extra calcium the only one, or are there other things that we can do? Who wants to answer that?
I can just shortly say, so magnesium is very, very good if you have like, you can reduce the calcium load, and you can also use magnesium, but magnesium, if you take too much, you will get diarrhea, or you would have stomach problems. So it's good to have a special kind of at least 300 milligrams magnesium for the basic situation. And then, as I showed you from the slides, I try to show you that it's not, that it probably makes no sense to adapt shortly a vitamin D treatment, or to adapt hormone treatment possibly, but this is very difficult. So calcium is one of the most important things. So then you can increase the calcium situation. So if you have, but it has to be solved individually depending on what sort of problems and symptoms you have. That's my point. Simone, perhaps you want to add your experience.
No, I totally agree. Calcium and magnesium are, the methods of choice. I could not think of anything else right now.
We have also a question from Valerie, who is asking, will there be a calcium meter so we can check the calcium?
It's great. There's one for animals already. Oh, Bill is commenting. I know there's some for animals, but which can't be used in humans. So Bill wants to comment on this. Perhaps he has new information on it. Bill, you raised your hand.
Yes, there's been a lot of work. I worked with Coney, I've worked with Abbott, I've worked with several companies in the development of new ionized calcium sensing receptors. And there's a group in London last year at the BES presented their data on a new calcium sensing machine that they've been in conjunction with a company developing. So the technology is improving. We're not there yet, but in the future there will be a measurement of calcium available at near patient testing. The technology at present, Abbott's technology, is too complicated. Also, ionized calcium is not easy to measure, and people falsely assume it's not affected by proteins. It's markedly affected by protein changes. So at the moment, we have 3 types of ionized calcium sensing receptors, but they respond differently depending on the protein concentration. So therein lies the problem. It's developing the ionized technology, having the computer power in a handheld device that has limited its application. But I can assure you, myself and others have been working on this for a good number of years, and it will become available in the future. The technology improves day on day.
So for the shorter perspective, the patients had to rely on symptomatology. Is that what you're saying, Bill?
I think what I find with my patients is that they're a little reticent to go and get the doctor to do a measurement. Now, what I do in Norwich is I send the forms out and I get the patients to do a measurement. One of the slides I'm going to put up is I'm going to question what people think symptomatology is in terms of low calcium and high calcium. I'm going to challenge that a little bit, Jens. So I think you have to have it measured. At the end of the day, measurements are very, very important. If I have a patient who phones me and say they're having a struggle, I say, I want to know what your measurement is. And a lab measurement is absolutely essential. And no patient should be refused a lab measurement if they're having symptoms, if they're having problems. I have a constant battle with GPs who won't do the tests, but I do placate all to get proper lab measurements of their adjusted calcium so that we can manage this very important condition correctly. The future, there will be handheld devices.
Thank you very much, Bill. So I think we maybe should spend the last few minutes of this session on talking about complications, because we know that these fluctuations in calcium levels might, of course, affect the quality of life here, but also be correlated to late complications. What do you think? What are your thoughts on the risk of complications, Simone and Pernian? And how do you think about it, Heidi? We have 3 minutes for this. Simone, would you start out?
Yes, I had kidney failure once, and I live in a country where you have very good access to emergency care. So I do not care about this so much anymore. This is maybe I hand over to Pernie Ann. I know that I will be supported if there is any emergency. So that's okay with me.
Yes, I myself is thinking about what can happen when I get this calcium failures on the brain, or brain attack or heart attack, and also characters. I already had to take an operation for that, and I know that many of our members is afraid for what can happen because of all the calcium that we are taking every day. So that is something that worries all our members. So maybe Heidi can say something about that.
Interestingly, it seems not to be, as far as the data are concerned, as not dependent on the amount of calcium you take, but is dependent on the calcium level. So if you have in between high levels of calcium, seems to be more dangerous, for example, for the kidney as instead of low levels of calcium. And what is really important seems to be the calcium phosphate product. So it's that and the hypercalciuria seems to be really relevant. So we have some areas of medication, what we know, what is important for the complications. We know, that the kidney is very important, but we learned in the last years that also infections are really important. And this is just also a new area of investigations that why, for example, infections are increased. So we have a number of complications. Everybody is focused on the kidney, and that's really important. But that does not seem to be, so there's a correlation to hypercalciuria, and that's again, okay, this is dependent also on the amount of calcium, on your calcium intake. But there is a difference between patients between hypercalciuria, not hypercalciuria. So there will be also genetic aspects who will get hypercalciuria and who will not get hypercalciuria. Perhaps Jens, you can also comment on complications.
Yes, I think we, in the interest of time, we also have to round out now. But what I want to stress here is, or what I think we should stress here is that there are two aspects. There are the daily life aspects that affect your well-being in the short term, in the matter of the day. But then we have a chronic disease. We have a chronic disease that starts abruptly if it is post-surgical, or is inherited if it is related to a genetic disorder. We know that complications, or at least data shows us that the complications, the long-term complications, are correlated to the time of exposure. So that is the time you have had the disease. So that will be a long time if it is idiopathic hypoparathyroidism, and it will be since the operation if you have post-surgical hypoparathyroidism. The whole concept and the idea, I think, is that we have to aim at a more physiological treatment that we thereby can reduce the risk of complications, because you have the disease or in a very long perspective, and thereby we have to also be aware of not only the daily life, but also the long-term risk of getting side effects of the disease. And if you have any short comments to this, then otherwise we have to just stop for the break now. Perny Ann, Simone, Heide. Thank you so very much for this first session.